Welcome to the Let's Get Comfy podcast. I'm your energy host, Norman Harris, and today we're honored to be joined by a true leader in long-term care and healthcare administration, Miss Maureen McCarthy. Big hand cloud. Yes. Miss McCarthy is the founder and CEO of Celtic Consulting and the education chair for the American College of Healthcare Administrators. Now, one thing I love to do on the Let's Get Comfy podcast, I put healthcare professionals in a little odd situation because I forced them to talk about themselves at the beginning of the show. Healthcare professionals are real sort of modest and they don't like to brag on themselves. But Miss Maureen, on this show, I believe in elevating and uplifting healthcare professionals. So I want you to go crazy and wow. Talk about yourself, brag about yourself today. Tell us what you do. Tell us what you accomplished.
Well, I've been in long-term care this is coming into my 40th year. So I've been around, for a bit and I've seen a lot of changes. I like to volunteer because I think once you get to a certain part of your career, it's your responsibility to give back. So I do volunteer. Like you had mentioned, I'm the chair of the education committee here at the college, helping them to decide what type of education comes in for the administrators to make sure that we keep them up to speed. I'm also the chair of the board for the American Association of Post-Acute Care Nursing, involved with that organization for a number of years. I'm a master teacher with them as well, so I teach some of the certification courses that they've had. I've written 6 books on long-term care subjects. I
6.
6, yep, you might be able to see, whoop, a couple of those right
Ooh. All
there.
right.
Yeah, and I present regularly on many different subjects because my background, which is a little bit unique, is I was a director of nursing. I was a care plan coordinator, and then we developed the MDS, minimum data set, as a screening tool for patients. So then I became an MDS coordinator because you needed a registered nurse to be able to coordinate that, and a
Right.
Medicare biller and a rehab director. So mostly the things I know about nursing homes, Norman, are because I'm nosy.
Well, you come with just a wealth of knowledge, and you're the true definition of industry expert. And upcoming, as you know, the 2026 ACHCA convention and expo is just around the corner. We know this conversation will offer incredible insights for our listeners. So, on this episode, we'll get into talking about managed care, quality improvement, and person-centered care, 3 of the most impactful forces shaping healthcare today. So let's get started with our conversation. And wonderful introduction, 6 books. Wow. I have a long way to go, Miss Maureen. A long way to go for sure. All right. So, first topic of the day is how can leaders turn managed care requirements into opportunities for quality leadership?
I think that the best way that leaders today can help support their teams when it comes to managed care or Medicare Advantage is to really encourage them to fight the appeals. We're getting so many denials of service and denials of care for the beneficiaries that we serve, and it's heartbreaking to know what they need, have the ability to be able to provide that, and then have the payer turn you down when we know
Mm,
that the patient can really benefit from this additional care. So I think that probably the number one way that our healthcare leaders can support their staff and support their patients or residents would be to help them to understand the process and help them to appeal the process when they do get that care denied, because everyone loses. The resident may have still received the care, the facility's not being paid for it, but it also sort of makes you look with a slanted eye towards that payer and taking another patient that belongs to that payer source.
right.
Because if you didn't pay me the first 3 times I took your patients, that makes me leery about that you probably won't pay me. So I may look at an admission point to take a different payer who may be a more guaranteed, payer source.
Right, right. So on this show, my platform is centered around providing information and resources to our caregivers and just the everyday community member that may not be in the healthcare space. So, in terms of individuals that may not be as familiar with what we're speaking about right now today, can you sort of explain to them how this could potentially impact them?
You bet. Last year, more than 54% of all Medicare beneficiaries were part of a Medicare Advantage plan, which is more than half of all beneficiaries in the entire country. We saw a little bit of a pullback this year in 2025, but I think it's because beneficiaries are getting educated as to the products that are available for them out there. And they want a product that they can count on and know that when they need care, they can go to the provider of their choice and receive those services. I think that, the public is becoming a lot more educated on the products that are out there. And I think that when they have choices, they're sticking with what they know, traditional Medicare, versus going with a Medicare Advantage plan where your physician may pull out of that plan, your hospital network may pull out of that plan, and
So
then
true.
and then you have that insurance, but you have nowhere to go because no one's taking that payer because they're so poor to deal with on the provider side. So it does end up impacting our beneficiaries as well. And that's something that really breaks my heart. And something that I always try and fight for is that they get the care that they deserve because they've been paying into this program for their entire lives. They should access the care when they need it.
I 100% agree with that. 100% agree with that. Miss McCarthy, one thing when researching Celtic Consulting, one thing I noticed about your organization is person-centered care is a focus point, right?
It sure is.
Yes, ma'am. So with advancing person-centered care in every setting, what does person-centered care look like when it's done right? And how does it improve lives?
Well, Norman, I'm so glad that you asked me that question because this is something that's close to my heart. My grandparents were both, in a nursing home. My grandfather was the resident council president. He made my grandmother be his secretary so she could take notes for him. And it really gave me the first glimpse of person-centered care, probably about 30 years ago now. And that was the opportunity because he had worked in a shop his whole life. And so he was up very, very early in the morning. He worked the 6 to 2 shift. So he'd be getting up at like 4 o'clock in the morning. And when you get into a nursing home, your cycle of when you sleep may be a little bit different, but you're generally sticking with the patterns that you've had your entire life. So he would get up at 3:30 in the morning. They would keep saying, "Go back to bed, go back to bed," and I'm saying to them, "He's not going to go back to bed. This is his waking up.
Right.
Let's give him a job, so let him pass out the newspapers, let him, do something he's interested." Then he comes back to the unit because he wanted a cup of coffee, and then he'll go back to bed after the breakfast trays come and lie down. But person centered means working around what that person's schedule is and what their preference is, and looking at ways that we can incorporate the care that we have to provide for those patients, but doing it within a way that's acceptable to them. And
Yes.
so I think that we need to put more focus on, care planning or planning care for the patient and not for the surveyors who may be coming in and saying, "Oh, well, you should have this on your care plan." It really should be focused on as a map on how that person prefers to be taken care of. If
Right.
I prefer this type of caregiver, if I prefer to, sleep late, get up early, eat at this certain time, we should be looking at ways that we can provide the care within the confines of what that patient determines to be acceptable.
100% agree. And that's probably a lot of the focus here in Florida, probably over the course of the last 2 years, has been aging in place. And that's probably contributed to that person centered approach and actually creating the care plan right around the patients. And a lot of times people do better in their setting that they're comfortable with, for sure.
Agreed. Agreed. And then if we can look at the care that they would prefer to receive and find a way to provide that care for them, there's no need for them to have to move to another level of care if we can get that care provided in the setting that they prefer.
Right, right. And there's so many different ways now with just mobile physician practices. There's so many different mobile healthcare professionals out there nowadays where it is very possible to do that and still provide the quality, right?
Absolutely. You have telehealth opportunities, and those have exploded during COVID because it was something that was available, and CMS really had constraints around the platforms that you had to use and things like that. But when COVID came and we were able to use things like FaceTime or Zoom meetings and team meetings and things like that, it really opened up a world for patients to get access to a healthcare professional that they may not have had access to before. You got to think about the rural areas of the country where you may not have that type of physician in 200, 300 miles. What are you
Right.
going to do? So it gives us a real a real, opportunity to be able to provide care and services for someone that normally may not be able to access that.
That is yes, yes. And I think about that when you mentioned about rural areas and I look at just quality, right? They one access to care may be limited in those areas, but also quality of the care as well can be impacted. And just speaking of quality improvement, with us dealing with that in healthcare and from a leadership standpoint, how can quality not be, I guess, focused on from a report standpoint, just focusing on data? In my mind, quality should be, we live it every day, right?
I agree.
Not just the reports. So if you could just expound on quality when it comes to providing it in different areas in healthcare, whether it's in a rural area in the city where it's more, I guess, convenient. If you can sort of expound on that.
You bet, you bet. And quality assurance and performance improvement is something that's close to my heart. And once I learned to think this way after working in long-term care, it changed the way that I look at everything. I approach everything with a quality assurance and performance improvement eye to it. Opportunities where what can possibly fall through the cracks? What are there some parts of the system that you haven't thought of? So making sure that all of those pieces of the system, function appropriately and the way that you want them to function so that you can move on. So when it comes to quality assurance and quality improvement in a nursing home, as you mentioned, we have a plethora of data that comes at us every day. We have data within our own electronic medical records. We have data that comes back to us from CMS and many, many different areas. We are overloaded with data in long-term care. But on the same token, we can also use that data to make improvements. Now, there's some that can be data driven and some that needs to be observed,
Hmm.
to be observed because we want the patient to have the best possible outcome that they can. And many times when people think about nursing homes, they think about them as facilities where people go because they can't take care of themselves and that they never go home again. That's
Right.
not what a nursing home is in this century, in the 21st century. They're mainly centers for someone to get care, to be able to go back and to be able to perform within their own home care setting, whatever that is. So it may be a boarding home, it may be, their own apartment, condo, home, whatever it is. But we want them to be able to function at the highest practicable level once we get them out into the community. So we can use the data to make improvements, to track where we are, use it as your bench line, where am I, as well as your threshold to say, where do I want to be? Where is everybody else? If I have 50% of my building that's fallen in the last year, what does everyone else look like? Are they at 30 or are they at 70? Am I good or am I, way out of whack? And then look at the actual system or program that you've got around that. So if it's falls, we have talked about falls. Let's look at how do you identify if someone may be at a risk for a fall? How often do you assess that person? What if their homeostasis, so to speak, or their level baseline has changed? Maybe they're a high risk now, or they've improved and they've got gotten a lot of rehab, so they're a lower risk now. So
Yes.
look at those opportunities, whether the care area is falls or infections or the ability to care for yourself. We have opportunities that we can use that can measure how well that we're performing and how much better we're getting at that all the time. And we should strive to give the patients that we serve the best possible care under the circumstances that they would like the care given.
Yes. I 100% agree with that. When I look at changes in healthcare, I think about the impact of the restorative program for those patients that may not be on therapy services. You're familiar with restorative, right?
It's one of my all-time favorite programs in long-term care. When I first started out, I had a restorative program in my facility when I was a director of nursing. And then when I got out there and I saw how good it worked, I was a big proponent of restorative care for many, many years. And the feedback that I would get was that it doesn't bring enough money into the building, so it's not worth it for the program. And I'm like, it's not about the money, it's about the person. And
Yes.
it's about and you can use it many, many different ways. You can use restorative nursing to be able to substitute when you don't have a rehab, program in your setting, or if the patient isn't a candidate for rehab. So maybe they have some dementia and they don't follow through, with the instructions that you give them so that they can do it on their own. But we can help from a restorative perspective because we can help the patient to become more independent. We can strengthen them so they're not as much of a fall risk. We can help to strengthen them so that they can participate in their own care and maybe help dress themselves or feed themselves or whatever we can do to make them more independent. So this is a program that's been close to my heart for a very long time, because I believe that the best way to use it is when someone's coming in for short term and they've practiced with rehab and they're on their rehab program and rehab's ready to discharge them. Let's have the person practice in the nursing home what they've learned from rehab, so we make sure that they've mastered the strategies before they go home.
Yes.
So they're not falling. They're not, having difficulty getting to the bathroom. We're going to let them practice and not help them in the beginning. And then if we find that they're not successful enough to be able to be discharged to the community, then we bring rehab right back in, work with them for a couple more days until they are strong enough. But if they're not strong enough, one of the things that we don't want to happen is to have someone go home and they toilet themselves and they fall off the toilet and no one finds them. It just doesn't do a good service to that person that you discharge. So when we're looking at making sure that that person's strong enough, you can either bring rehab in, or now you're satisfied. You let them practice for a day or two and you're satisfied that Mrs. Jones is not going to fall off the toilet when she goes home. I'm comfortable. I let her practice for a couple days with the aides. We didn't have to bring them back in. Now we're ready to let her go. I think that's
Yes.
one of the best ways.
Well, I brought that up when we were speaking about quality improvement, and I'm noticing a trend in some skilled nursing facilities, not all of them, that the restorative program has been sort of dissipated, they're on a decline, like where they're not having as many restorative, CNAs assigned, on the shifts. And I just feel like that is a disservice to, the patients that we serve. But also, if you look at it from a, I guess, PPD standpoint, right, for CNA coverage, but I just wanted you to, I thank you for so eloquently expounding on the importance of the restorative program, because it's really important.
And I have a solution to your problem, which is you don't have a separate restorative aide that provides the service. The CNA that takes care of that patient every day should be providing that restorative service. Now, it's our job as leaders in the facility to make sure that the assignment that CNA has, which is the list of patients that they're taking care of for the day, isn't bogged down with too many people on one assignment that are on a restorative program. But the CNAs should be intimately involved with what's going on with that program. They see that patient every day, especially now with culture change that we have consistent assignment. They're usually taking care of the majority of patients that they take care of are the same every day. And that gives us a better continuity of care because, like I was talking about with my grandfather, his 11 to 7 CNA, I mean, darn well they're getting that coffee from the staff break room. The kitchen isn't even open yet at 3:30 in the morning, right? But he
Yes.
wanted that person still there so that he knew when she was there, she was going to get him his coffee. He's going to go around and pass out the newspapers. He's going to have a great day. And no matter who the patient is, I think they all, deserve that to be cared for in the way that they prefer. And I think that restorative nursing can help get a lot of people there. And the relationship between the patient and the aide is a lot closer than the patient and the nurse, I find. And so sometimes the patients will perform for the CNAs even when they don't want to, because they really like them and they want to please them.
That continuity of care, having that personal connection with them. I always say those your CNAs and nurses are your eyes and ears. They know your patients the best, for sure. So I definitely concur with that. So we're moving towards a hot topic. So I wanted to discuss a hot topic. Is maybe not trending so much right now, but it is a hot topic, and I'd love to have your take on it. But it's regarding trending policy and innovation in care delivery. So policy and innovation, there aren't just headlines; they're shaping how we deliver care. So healthcare policy shifts will change the business of care in 2026. So I have an article here from Definitive Healthcare, and it speaks on, and this is back in July, okay, of 2025. Congress passed the bill. The 2025 passed the 2025 Budget Reconciliation Act, nicknamed the One Big Beautiful Bill. The new law will have significant impacts across Medicaid, the Affordable Care Act, food nutrition programs, and more, and cuts more than $1 trillion in healthcare spending over the next decade. Industry analysts and the Congressional Budget Office estimated that millions of people could lose health coverage by 2034. Hospitals, especially rural facilities, are bracing for higher levels of uncompensated care, in some cases, possible closure. Are you familiar with the One Big Beautiful Bill?
Yes, Nora, and I think most of the country at this point is familiar with OB3.
OB3. Yes. So share your thoughts on it with me
Well, I
today.
think that if it does happen that Medicaid is no longer funded, it will implode the healthcare system of the entire country. Um, but the other thing is that we've seen so many times that tariffs are going into place, not going into place, going, coming and going and coming and going. It's almost like a wait and see attitude at this point in time to say
Mhm.
what's really going to happen versus what's threatened. So I think we need to really see what's going to happen in each one of the states. I know that some have their own sort of slush funds or rainy day funds that they're utilizing some funds to be able to put the money back into the Medicaid programs where it's getting cut. And I think that long term care supports and services may have more of a problem than long term care, institutional care. But still, it's going to be a problem for everyone. And just looking at patients who are qualifying for Medicaid and, you know, whether that will still um, be happening down the road, and will the qualifications change, and not just the funding, but there can be a lot of changes down the road that can really have a significant impact. We are able to provide more long-term care supports and services in the home settings now than we have historically, but we're
Yes.
not there yet, providing 24-hour care for people. So we still need inpatient settings to take care of people who need inpatient care. And so I think that uh, to look at the program, is there some waste in the program? I'm sure that there is. I think if you interview anyone that works in long-term care, they could tell you right where some of that is. But to not fund it and to leave these people without care, we saw something very similar back in the 80s when they closed all of the mental health institutions that we had, and the patients were discharged out into the streets, or some came into nursing homes. Many of us were not ready to take that level of patient in a nursing home at that point in time. We mainly had, you know, elderly people who needed assistance with ADLs and maybe a little bit of dementia. The population that we serve now is nothing like the population that we served when I first started 40 years ago.
No, no, it's not. It's not. The age range is wider now as well. You have definitely more, I guess, psychotropic medications involved at the skilled nursing level for sure now as well. Psychiatry and psychology is more prevalent for sure. So you definitely, though I wasn't, I don't have the 40-year experience as you do, but I do know that psychiatry definitely makes an impact right in healthcare right now for sure.
And we're seeing so many more patients that have behavioral needs that we haven't seen before. And the payment systems that we're working with are based on acute care patients, not patients with behavioral needs. So, if they can take some of those case mix points and the weights out of, some of the higher categories, for instance, in Medicaid programs, looking at taking some of the case mix weights out of the category that looks at the trach and the vent. If your facility has a ventilator unit, you have a special rate. So let's take those case mix points and put them down in the behavior categories where they can really be useful to help us with that population.
Hmm.
Long-term patients aren't looking for, IVs and some rehab and they're going home. No, these patients are there because they have a long-term need. And how can we meet that with this short-term payment methodology?
Right, and most times it's their home, you know, for them. A lot of people or individuals, their living circumstances are different. Right, they don't have a home, or they don't have someone, a loved one close to them that could take care of them. And like you said, our healthcare system isn't as advanced to provide 24-hour care in the home at this time.
You're
Right.
you're correct. And you had
Yes.
mentioned different payment models. that were coming down and different changes in opportunities. And we have, I-SNPs and D-SNPs that are out there now. You have the ACOs, or accountable care organizations, and you have, new models that are coming out. They've got the TEAMS model that they're looking at now for, orthopedic opportunities, and then directly sending those patients to the nursing home. So I think that CMS is trying to be innovative with what they're trying to put out there. But I think they really need to take off the blinders when it comes to the Medicare Advantage, though. I think that they've been blinded for so many years because they don't receive the claims and they don't receive the MDSs for those patients. So they're limited with what they're allowed to see when it comes to, the data that can be extracted from that. But I think that, as they start to look into it more, I think they will be very surprised and to find out what's happening out here with these providers.
Yeah. So, Miss Maureen, if you could share with the audience, because today, our conversation today is essentially a teaser, right, for the 2026 ACHCA convention and expo. Can you tell the audience here today what would your contribution, your sessions that they possibly will see you at?
You bet. Well, we're doing a pre-conference to start off the what we used to call convocation, but the conference. And I'll be presenting with my colleague Leah Klusch. And she and I have been in the business for a very long time. Leah is a great mentor of mine. And we're going to be talking about some of the subjects that we talked about today. We're going to be talking about payment models. We're going to be talking about compliance. We're going to be talking about some of the industry updates that have come along in the last year. We're going to be talking about value and quality and ways that they can improve their value. I'm also doing another session that's going to be talking about audits that are coming out of quality. Now we have payment audits, a plethora of payment audits. Now we're looking at quality audits starting that CMS is going to be rolling out. And they just started that this month in January. So we're going to tell providers what to expect, how to prepare, how to pass or fail the audit. And then we've got some other great sessions out there. We've got sessions on QAPI. We've got sessions on facility assessment. We've got courses that are out there for a conference. We've got a special section for new emerging leaders as well, so that they can look at opportunities that they would need that might be different than someone who's a seasoned administrator, and a huge focus on technology with artificial intelligence, right at our heels in long-term care and in healthcare in general. We're going to be talking about opportunities that may be coming down in healthcare that will involve AI as well.
Oh, AI, I love that. So, typically, what professions do you encounter at the previous ACHCA conferences? What professions would you say? Physicians? You say nursing home administrators?
I've been attending this conference, and I've been a member on and off since the 80s of this group. And I've been attending a conference for a long, long time. Obviously, the majority of people are administrators because it's the American college, but directors of nursing, your corporate team is there as well. We see people who want to become leaders, someone who may want to study to become an administrator there as well. So your corporate department heads, within the facility, your leadership within your organization, administrators, directors of nursing, MDS coordinators, rehab managers, admissions directors, sometimes heads of social services departments we'll
Yes.
see at conferences as well. Our billers will be there, our finance folks, CFOs, there's compliance folks, the compliance officers. It's a great place to get education for compliance officers as well. And those are generally the folks that we see, the leadership teams within the nursing homes and then the corporate structures.
Okay. Now, do you have any other extensions you would recommend, right, to actually attend and come? Any other extensions?
Yeah, I would
Um,
say any of your facility team that you're looking to grow as leaders, whether they're going to be an administrator or not, I think it's a great opportunity for them to have the ability to see what a conference looks like for a professional group, so that they can network while they're there, talk with other people that work in the same department as they do, and then just, sometimes networking and exchanging ideas. Well, how do you manage this? Oh, did you hear that this is coming down the pike? And what's your team doing about that? So just an opportunity to network with people from other facilities, sister facilities, if you're part of a chain and, getting to catch back up. I find that that's one of the things that people really like the best about the conference is that they're able to see people that they only see once a year at this conference. So they're
Almost
able to,
like a reunion,
yes,
a
exactly.
retreat, so to speak. Yes, yeah.
Exactly.
So what's the one idea you want every leader taking back from ACHCA this year? What's one idea?
I think this year, the idea would be to embrace AI because it can help you with your job. Don't be afraid of it. We'll work our way through it. Is it a little bit scary right now? Sure. It's brand new. Everything's brand new is always scary. But I think really to embrace it because I think it's going to make them more efficient and save them time in their day every single day, no matter what department you're ahead of, whether it's maintenance, nursing, admissions, social service, recreation, or the facility leadership team themselves. I would say embrace technology.
Embrace it, technology. So the 2026 ACHCA, I have to practice that saying that multiple times. All the HCACA convention and expo is right around the corner. Uh, I'm so excited. I'm looking forward to meeting Miss McCarthy in person for sure. I'll be there. Miss McCarthy, do you have any final words you'd like to share with the audience today?
I just would love everybody to be able to come to the conference and come and stop and say hello. We're going to have a booth there, and we'll be around the conference. So if you're looking to do an education session next year, if you're just having fun at the conference, if you want to get involved with the organization, absolutely stop. I'll introduce you to people, but come enjoy. You'll have a great time and you'll meet a lot of great people.
2026 ACHCA convention and expo. We'll see you there.
Sounds good.
Thank you. All right, that's it. You knocked that out. You knocked that out.